everyone, this is Dr. Raghavi. We are back with another video for the Kickstart series, and this one is on vaginal discharge. I know all of us wish for a ready reckoner when it comes to sexually transmitted infections or vaginal discharge, a single place where you could refer and revise before exams. And this video is that ready reckoner revision guide for this topic. I believe that whenever you have a very big task, you can make it into smaller pieces and do whatever you can in a day because you will never have this day again. So just make it count. When it comes to vaginal discharge or sexually transmitted infections, we need to know about the causative organism, specific unique identification points that would pinpoint that organism, and how do we diagnose it? Where do we take the swab from? Do we take it from the vulva? Do we take it from the vagina? Do we take it from endocervix? Do we need an urethral swab? Everything will be dealt with. What is the treatment of choice for that particular infection? And does that infection need a test of cure? And is there a role for contact tracing? Test of cure means whether that particular patient, after being diagnosed with an infection and treated, needs a follow-up identification test to confirm that the infection is completely eradicated. This is required in few organisms. On the other hand, contact tracing implies tracing all the sexual partners of an index patient in the previous months to weeks based on the nature of the organism and testing or treating them for the same infection if present. So we'll first start with bacterial vaginosis. It is the most common cause of abnormal vaginal discharge in women of childbearing age. As we all know, it is because of an alteration in the normal bacterial flora of the vagina, leading to an overgrowth of anaerobic bacteria in the vagina, which causes a more alkaline environment from the usual acidic protective one. So here the pH becomes more than 4.5. Fishy smelling discharge is typical and BV is not considered to be a sexually transmitted disease. It is more common in women with intrauterine contraceptive devices and smokers. The diagnostic criteria for VV is an often repeated question, and it includes Amsel's criteria, in which you need to have at least 3 out of these 4 features to confirm bacterial vaginosis. So, the discharge in BV should be thin, white and homogeneous. When you look on the discharge under a microscopy, you should be able to see clue cells, which are vaginal epithelial cells surrounded by the bacteria. Then the pH of the vaginal fluid should be more than 4.5. When you add 10% potassium hydroxide to the fluid, it should release a fishy odor. The presence of any 3 out of these 4 features confirms a diagnosis of bacterial vaginosis. The other criteria for this include Hay or Eissen's criteria, where it is classified into 3. Grade 1 or normal is lactobacillus morphotypes are predominant. These are the normal bacilli found in the vaginal flora. In grade 2, it is an intermediate where there is mixing of flora with some lactobacilli still present, but the Gardnerella or Mobilenchus morphotypes are also seen. In grade 3, that is in bacterial vaginosis, predominantly Gardnerella and or Mobilenchus morphotypes are seen, while the lactobacilli or few are completely absent, and this is diagnostic of bacterial vaginosis. The other score is Nugent score. Here it estimates the relative proportions of bacterial morphotypes to give a score between 0 to 10. So if whenever the proportion of other bacterial morphotypes is high, it means that there is anaerobic bacterial proliferation and it is BV. So whenever the other bacterial morphocytes are less than 4, it is normal. If their proportion is 4 to 6, it is intermediate, and if it is more than 6, it is diagnostic of BV. So how do we treat bacterial vaginosis? The first choice of drug is always clenbuterol, and the dose is going to be 400 micromg twice daily for about 5 to 7 days. But however, when you are prescribing metronidazole, you should inform the patient that they should avoid alcohol during the duration of metronidazole and for 48 hours afterwards, because taking alcohol when on metronidazole can lead to disulfiram-like reactions. Or you can tell them to use a clindamycin cream 2%, where 5 gram is inserted intravaginally at night for 7 nights. But usually clindamycin cream is avoided in first trimester of pregnancy, and clindamycin can weaken latex condoms or diaphragms and should not be used during the treatment and for 72 hours after the treatment as well. You can also prescribe clindamycin capsules, which can be given at a dose of 300 mg orally every 12 hours, and the duration of treatment is again for 7 days. Okay, so we have a question here. A 20-year-old woman presents to the sexual health clinic with a grey-white offensive homogeneous vaginal discharge. Microscopy of the discharge revealed clue cells with a positive whiff test. This is most likely due to, well, here you can see it is in sexually active women, and the discharge is white and homogeneous. There is clue cells, and with a positive whiff test, that is, there is fishy odor on adding potassium hydroxide to that discharge. This satisfies 3 out of the 4 criteria in Amsel's diagnosis. So the diagnosis is going to be bacterial vaginosis. Okay, now we'll move on to the next organism. As you can see, this is a picture which might be given in your exam, showing a cervix with a thick curdy white discharge, which is diagnostic of vulvovaginal candidiasis. A candidiasis can be classified as acute or recurrent. If it is the first or a single isolated presentation, then it is acute. It is called as recurrent when there have been at least 4 episodes in the past 12 months, with at least 2 episodes confirmed by microscopy or culture when symptomatic, and there is at least 1 culture confirmation. Etiology of vulvovaginal candidiasis, mostly due to Candida albicans in 80%. Other Candida species or yeast such as Candida glabrata, tropicalis, cruzae, and paracellosis and Saccharomyces cerevisiae can happen in the remainder of patients. Most commonly, Candida presents with vulval itch, and the discharge in Candida is non-offensive, and it is curdy white. Other symptoms can include soreness or burning. There can also be superficial dyspareunia. And in Candida, always take a high vaginal swab of the discharge, and it can be taken for a gram stain or a phase contrast wet film microscopy. Under the microscope, this is what you are going to see. You can see blastospores, pseudohyphae and neutrophils. This picture is indicative of an infection caused by Candida species. So how do we treat it? Well, in acute VVC, diagnose by microscopy for blastospore or pseudohyphae presentation and treat with a single dose of fluconazole 150 mg oral stat. The second line is clotrimazole 500 mg per vaginally. On the other hand, if it is a recurrent VVC which has good or complete response to treatment each time, go for microscopy and high vaginal swab for fungal culture to identify, that is, whether it is Candida albicans or non-albicans Candida, and also for sensitivity testing as to whether it responds to fluconazole or not. So if we find it is Candida which is fluconazole susceptible, then go for suppressive therapy with induction. That is, go for 150 mg 3 times a week of fluconazole oral, then weekly 150 mg of fluconazole for 6 months. On the other hand, if it is fluconazole resistant candida, the treatment is going to be 100,000 international unit nystatin pessaries for 14 nights. If it is again a recurrent vulvovaginal candidiasis, which is having only poor or partial response to treatment, go for microscopy, high vaginal swab for fungal culture, organism identification and full sensitivity testing. If it is azole resistant candida, the treatment is going to be 100,000 international unit nystatin pessaries for 14 nights. If it is resistant to nystatin as well, go for boric acid 600 mg pessaries for 14 nights and you're done. On the other hand, always in case of recurrent VVC, rule out lichen sclerosis and vulval pain syndromes. So simple, acute candida, treat with fluconazole 150 mg stat. If it is recurrent, look for high vaginal swab, culture, microscopy and resistance testing. Identify the organism, look for its sensitivity, sensitive to fluconazole, start with weekly 3 doses of oral fluconazole and continue for weekly fluconazole for at least about a period of 6 months. Resistant to fluconazole, nystatin 100,000 international units vaginally for 2 weeks. Resistant to nystatin as well, go for boric acid 600 mg pessaries for about 2 weeks. And if always in case of poor or partially responding to treatment, consider alternative diagnosis such as lichen sclerosis, vulval pain syndromes, etc. So what is this? This is the third organism that I wanted to discuss to you about. As you can see, this is Trichomonas vaginalis. TV is a flagellated protozoan. In women, it is found in vagina, urethra and paraurethral glands. 10 to 50% of women with TB infection are asymptomatic, while vaginal discharge can be seen in women up to 70%. However, it varies in consistency from thin and scanty to profuse and thick. The classical frothy yellow discharge, which has always been mentioned in our gynec books, occurs in 10 to 30% of women only. Approximately, the strawberry cervix due to petechial hemorrhages on the cervix is seen in only 2% of the patients. In naked eye, higher rates can be seen on colposcopic examination. So TB, the diagnosis is going to be saline drop test. Take the discharge, add saline, put it under the wet mount microscope and look for motile trachoma nuts. So treatment is going to be metronidazole 400 to 500 mg twice daily for 7 days or stat 2 gram orally in a single dose. However, sexual partners should be treated simultaneously. Patients should be advised to avoid sexual intercourse for at least 1 week and until they and their partners have completed their treatment and follow-up. Test of cure is recommended only if the patient remains symptomatic following treatment or if the symptoms recur. The optimum time of NAT for a TB test of cure is going to be 4 weeks after the start of treatment. Okay, so we have a 15-year-old attending the genitourinary medicine clinic complaining of vaginal itching and green vaginal discharge. She is sexually active with her 17-year-old boyfriend and uses the oral contraceptive pill. On speckle examination, we can see hemorrhages on her cervix. A UPT is negative. Considering the most likely diagnosis, what is the most appropriate first-line antibiotic? Here, in a sexually active girl with itching and green vaginal discharge, when there is a strawberry cervix on examination, the organism is going to be Trichomonas vaginalis and the appropriate first-line antibiotic in TB is metronidazole 400 mg twice daily for 5 to 7 days. So the answer here is D. So Trichomonas is the causative organism. There is often purulent vaginal discharge and the cervix may have the classic hemorrhages, giving it the classic description of a strawberry cervix. This patient should be advised that while the oral contraceptive pill is effective for preventing pregnancy, barrier methods should also be used to prevent sexually transmitted infections. treatment with metronidazole would be safe in pregnancy as well. What next? What is this organism? This is the gonorrhea, Neisseria gonorrhea, gram-negative diplococci. It can cause female urethral infections, endocervical infections because it colonizes the columnar or cuboidal epithelium. It can cause pharyngitis also. Investigation of choice, nucleic acid amplification testing or culture. Treatment is going to be ceftriaxone 1 gram intramuscular as a single dose or ciprofloxacin 500 mg oral a single dose. Alternatively, you can use cefixime 400 mg stat, gentamicin 240 mg IM plus azithromycin 2 gram orally can also be used. So concerning Neisseria, say true or false for each of this following statement. Neisseria meningitidis is a gram-positive cocci. No. Infection with Neisseria gonorrhea may cause suppurative urethritis in males. Yes, true. Neisseria gonorrhea is a commensal of the genital tract. No. Neisseria gonorrhea thrives in conditions with low levels of carbon dioxide. False. This organism actually thrives in carbon dioxide high medium and species are cultured on chocolate agar. Neisseria are from aerobic gram-negative cocci. Both Neisseria gonorrhea and meningitis are human pathogens. They are not commensals. They both prefer a moist environment with about 5 to 10% levels of carbon dioxide, while Neisseria meningitis is a commensal of the nasopharynx in about 10% of the population, with higher carriage rates among teenagers. Neisseria gonorrhea causes the sexually transmitted disease gonorrhea. It can be asymptomatic in up to 50% of women and can lead to pelvic inflammatory disease. Symptomatic individuals with gonorrhea may present with lower abdominal pain, increased or altered vaginal discharge or dysuria. The next organism that we are going to see is Chlamydia trachomatis. This can present as vaginal discharge, post-coital bleeding, intermenstrual bleeding, dysuria, lower abdominal pain, dyspareunia, mucopurulent cervicitis, pelvic tenderness and cervical motion tenderness. Diagnosis is going to be NAT in vulvovaginal swab, which is more sensitive than endocervical swab. Treatment is stat azithromycin 1 gram or doxycycline 100 mg oral for about 7 days twice daily. Alternative is erythromycin 500 mg twice daily for about 10 to 14 days. An 18-year-old woman comes to sexual health clinic requesting a sexually transmitted infection screen. Asymptomatic, however, she is concerned as her new boyfriend is complaining of dysuria, penile discharge and scrotal pain. What is the most likely cause of his symptoms? Here, when there is dysuria, penile discharge and scrotal pain, the most likely cause is going to be Chlamydia trachomatis, because these symptoms are suggestives of urethritis and this gram-negative intracellular bacterium can infect squamocolumnar epithelial cells is the most likely cause. Chlamydia is the most common cause of PID for your MCQs and may go on to cause subfertility and also increases the risk of ectopic pregnancy. So this is an overall table that I wanted to show you, which tells you the differentiation between clinical features of each of the organisms. So candidiasis, BV, TB and cervicitis due to chlamydia or gonorrhea. There is itching in candidiasis and trichomoniasis. The smell in candidiasis is usually non-offensive yeasty. BV is offensive. On trichomoniasis it may or may not be offensive. The color in candidiasis is white. It is curdy. Bacterial vaginosis is white or yellow. Trichomoniasis is yellow or green. Cervicitis is clear or colored. Consistency, it is usually thin homogeneous in BV and trichomoniasis. On the other hand, candidiasis supposedly has a curdy white discharge. Cervicitis can be mucoid since it is endocervical. The pH remains acidic in candidiasis and cervicitis, while in BV and TB it becomes alkaline. Method of confirmation is usually microscopy and culture. Microscopy in BV, trichomoniasis microscopies may also require culture or NAAT for confirmation. And again in cervicitis microscopy, go for NAT for specific for chlamydia and Neisseria gonorrhoeae as the suspicion indicates. So contact tracing for PID, contact tracing done for the previous 6 months, and all the partners in the previous 6 months are made to undergo a screening test and treat if required. Gonorrhea for 2 weeks, lymphogranuloma venereum all the previous 3 months, Mycoplasma genitalium the current partner needs to be treated. Trichomoniasis vaginalis, trace all the partners from the past 4 weeks and then treat them. And test of cure is not required in case of bacterial vaginosis or vulvovaginal candidiasis. In chlamydia after 5 weeks of completion of treatment, but only in pregnancy, not routinely done. Gonorrhea 72 hours after the single stat dose of azithromycin. Bacterial vaginosis, it is not done. Lymphogranuloma venereum 2 weeks after the completion of treatment. Vulvovaginal candidiasis, test of cure is not needed. Mycoplasma, do it after 5 weeks. So we have a 35-year-old woman presenting at a sexual health clinic with a new painless round lesion on his penis. He also has non-tender, again painless, inguinal lymphadenopathy. What is the most likely causative agent of his symptoms? Ulcers are another commonly asked questions in the MRCOG exam. You will get a variety of ulcers, either pictures or such descriptions, and I just wanted to give you an outline of this so that it would be easy for you to revise in the end. So this non-tender ulcer, that is a painless ulcer with a painless inguinal node, is more likely to be syphilis or Treponema pallidum infection. Treponema pallidum is causative agent for syphilis, and primary syphilis typically presents with a painless genital ulcer or a chancre alongside inguinal lymphadenopathy occurring 10 to 90 days after infection. Secondary syphilis develops within 2 years of infection and tertiary syphilis after this period. Screening tests for syphilis include the Venereal Disease Research Laboratory carbon antigen test and the rapid plasma reagent, that is RPA. Both of these tests can give false positives. More specific tests for syphilis include the fluorescent treponema antibody absorption test. So ulcers, just an equation. Whenever there is a painless ulcer with painless nodes, think of syphilis. Painful ulcer, painful nodes, and if there are bilateral nodes with systemic symptoms, think of herpes. Painful ulcer with unilateral nodes, think of chancroid caused by Haemophilus ducrei. Painless ulcer with painful inguinal lymphadenopathy, think of lymphogranuloma venereum. I have few pictures to show you. This is the chancroid caused by the Haemophilus ducrei. There are multiple ulcers. This is syphilis, where you can see the mucocutaneous rashes, that is a condyloma, and the single painless ulcer. These are pictures of lymphogranuloma venereum showing the inguinal lymphadenopathy, that is the groove sign. You can see 2 nodes with a groove in between. This is the groove sign characteristics of LGV. And this is the herpes, the vesicles seen on the genital area. This is going to be the ulcer. It can ulcerate, and these ulcers are extremely painful. The nodes are painful. Patient will have systemic symptoms as well. Thank you so much.